Our presentation is really a sliver of our 3-hour evidence-informed health advocacy training that we have developed with Developmental Disabilities Council here in Illinois years ago. And it was primarily aimed, or we tested it with 10 out of 11 pediatric residency programs, residents in those programs. And this is really building upon it's taking a little bit of a deeper dive and continuing the conversation from yesterday where we talked about and discussed interprofessional perspectives in health equity. We will introduce some really concepts of health advocacy and becoming an advocate and an ally in healthcare. I wanted to introduce Beth Marks. You kind of know her, but just really briefly, Beth is a co-director of HealthMatters program. Both myself and Beth are at the Department of Disability and Human Development at the University of Illinois at Chicago. Beth is also the past president of National Organization of Nurses with Disabilities. Beth, welcome.
Thank you, Jasmina. Can you hear me okay?
Yes.
And you can see the PowerPoint?
Yes.
Okay. Good morning. And Jasmina gave a quick overview of our presentation today. So I will go ahead. Maybe not. Okay. This is us. And it's divided up into 3 sections. And also I should say from the original study, we did an update a couple months ago as well to address more of the concepts that have come up since COVID. So it's divided into 3 sections: social determinants of health, accessing setting-based healthcare, healthcare interaction, uprooting systemic bias and ableism, and universal design, moving beyond ramp to cultural humility. And as a backdrop overview, Lisa Iazzoni, who is a physician up in Harvard who has a disability, came out with a lovely study in 2022. If you haven't seen it, it's worth reading and having. But what she found was of 714 US physicians in outpatient practice, 21% could not identify who paid for needed accommodation. 36% reported little or no knowledge about their legal responsibilities. And I should say the ADA was passed 32 years ago, so not new. 68% felt at risk for ADA lawsuit, and 71% did not know who determined accommodation. And so I like the picture about health disparities because it kind of highlights the long-lasting effects of disparity across generation, and closing the gap requires addressing SDOHs and differences in health linked to social or economic disadvantages. And for people with disability, there are 2 overarching issues. One, many people with disability do not share their disability status with their immediate family, particularly for people with IDD. They're not growing up in a family that they understand ableism within the context of their lives. And the other factor is that people with disability, we tend to still treat them from a medical lens and really view all of the problem from a medical, physical, mental, psychological perspective, and don't ever really address the social economic disadvantages. Another quick overview concept, and this is more or discussed more in universal design, but I think it really is overarching for a lot of the health advocacy concept. And I like the picture to the left. Sorry about that. I like the picture because we have as a logo for disabled, the wheelchair logo. And I think the concept of, we still in healthcare profession talk about people being wheelchair bound and confined to a wheelchair. And I think as a general statement, we need to ask people how they want to be referred. And many people who use a wheelchair really find that the wheelchair enables them to be in the world. And again, because a lot of people with disabilities have not had any sort of education around what ableism looks like, what universal design looks like. But I think, as Suzanne Smeltzer has found in her over 2 decades of work and looking at the nursing literature and nursing education, we really have done very little in terms of including disability in nursing education and having a different presentation. So I put this slide up here. There's a lot of information out there in terms of what we should be saying and what we don't say. And sorry, I gotta stop a second. Okay, I'm back. So I don't want to keep going over this, but I think because it's so ingrained in our education to think of people with disability from a medical model, when we can in one breath say, don't say wheelchair bound, and in the next breath talk about wheelchair bound. So it's really, this slide is just meant as a reminder that we all have to keep a check of what we say to people. Health advocacy defined. Okay, trying again. So it just Marie Humanette, she's up at British Columbia, and she has done some awesome work around health advocacy. So I really would encourage you to look up their literature, but she defines it as activities relating to ensuring access to care, navigating the system, mobilizing resources, addressing health inequities, influencing health policy, and creating system changes. And then the ARC also has, the ARC of the United States talks about self-advocates, and we like their policy statement that self-advocates can exercise their rights and must have a meaningful role in decision-making in all areas. And I think that's really been one of the overarching goals of the Gittin Fellowship, is really trying to figure out how we can best support people to advocate their rights. People with IDD have the right to advocate and be supported. So just some of the guiding principles, as I just said, people have the right, can contribute to their own well-being by becoming knowledgeable about their health and healthcare resources, active participant in their health and healthcare, and by including the underlying principles, we can maximize their involvement in planning and implementing health goals, and collaborative support from allies, servicing healthcare providers and policy entities. Okay, sorry. Levels of advocacy, health advocacy, there's really 3 different areas, and we try to cover this within the training and today's presentation, but really need to look at systemic policy. the efforts of many people. I think that the presentations that you all have done have been phenomenal. And as we can see, it takes many people to lead change on an individual level, not only for people with IDD, but all of us as healthcare professionals need to really appreciate what our role is and how to support each other. And then on a self level, just to constantly come up with new ideas. If you have a disability, there's constant opportunities to figure out how to do things better with healthcare interaction. So social determinant being visible, person-centered healthcare with equal access to healthcare is a civil right and advocacy issue. Really love this slide that Jasmina found. The environment affects health more than individual health behavior. And so if you look at fish one, would fish one be happy, safe, and healthy if its water were dirty? What if its bowl were cracked and the water was leaking out? And then fish two, no matter how much fish two tried, it may never reach its full potential, health potential, due to its dirty water and cracked bowl. And I think that really highlights the need for addressing social determinants of health across all healthcare areas, whether it's in ICU or in group home. Essential concept, so social determinants of health, large percent of health outcome, and where people live, learn, work, play, and pray, that comes from the WHO definition from 1986, the Ottawa Charter. If you haven't read it, it's about 40 years old, so it's worth looking at. Structural competency, health disparities across population, and really influenced by upstream social determinants of health. And then the upstream factors, important consideration for improving the health of an individual or population. Healthcare education and practice operating, oh crap, I can't say the word. We'll just skip it. It's controversial and challenging. We do have a cool project program at UIC Health in our hospital where they were having such a revolving door of people who were homeless that one of the physicians in the ER started a housing program where people, they essentially provided housing and found that people did much better in terms of being able to follow the medication and come back for appointments. So I think that's an example of upstream factors. So in other words, when people leave from ICU to the floor, making sure that people have housing and asking those critical questions of, do they have someone to take care of them when they go home? Key upstream factors, upstream intervention lead to health equity, healthcare approach, disrupt structural barriers, and transform quality of life and health outcome. The key factors that drive it, health inequities, are social inequity. So class, age, ethnicities, immigration status, gender, sexual orientation. I don't know why I keep bumping this. My apologies. Okay, I'll leave off, stop touching my mouse. And what's not their disability status. And the reason we keep fighting in the disability community, before Obama left office, they really tried to get disability included as an underserved population, but that did not happen. So that's probably one of the biggest issues that really needs to happen, so that we can have federal grants include disability and definition included as or when we talk about definitions of underserved communities, that disability is included. So words do matter. Institutional inequity, so corporations, businesses, government agencies, schools, law and regulation, nonprofit organization, and then living conditions. A lot of people with disabilities live in low-resourced communities where they have food deserts and inadequate healthcare, education, social services. And then downstream effect would include the patient health behaviors such as smoking, poor nutrition, low physical activity, violence, all the things that we typically address, but we fail to incorporate the upstream factors. So impact of SDOH, diagnostic overshadowing, clinical care, lack of training, bias, ableism among providers, accessible equipment, spaces, health literacy, engagement in quality care, health behavior, health promotion for healthy lifestyle, food, activity, sleep, etc., mental fitness, disease prevention, physical environment. We still struggle to have accessible and recreational activity, resident quality. I just was telling, I was back in Ohio over the weekend. A friend of mine is an occupational therapist working in a group home in Akron, a low-resourced area. She new to this area field, and all the things she described were all OG. It needed to be reported at OGI, and she really, it wasn't happening. So I was really just blown away, having worked in this area for so many years back in my home area, that what was happening was just blatant abuse coming from the top down. Social economic factors, limited social support, violence toward people with disability, living in various residential settings, participating in day program, all impact health. So, yes,
Can
ma'am.
you define diagnostic overshadowing in that slide?
Oh, yes. So diagnostic overshadowing is we tend to, it goes both ways, but we tend to focus on the disability. So when you come in with a, a stomach ulcer, we focus, or you come in with mental status changes and not being able to work and just not being yourself, and you're 29 years old, and everyone focuses on premature Alzheimer's disease and spend a lot of time, like a year or two, focusing on that. And meanwhile, you stop participating in, playing sports, being with your family, you stop working, you stop talking, you stop doing anything. And you find out 2 years later that you actually have a bleeding ulcer that could have been easily treated. That's one example of that's really typical, particularly among people with IDD, because we focus on behavioral. But sort of, newsflash, we all get sick and we all have behavioral changes, but many of us have family and friends who kind of point out, you seem different today, what's up? But if you have an intellectual developmental disability, we really are hyper focused on the behaviors rather than all behaviors have meaning. And conversely, it can go the other way, where people with intellectual disability might actually be, as they age, might actually have dementia stuff going on, but we miss that too. So we just miss. So the overshadowing is really focusing on the disability and not recognizing that people have very similar types of conditions that everyone else does without a disability. Did that work, Jasmina?
Yes, thank you.
Okay, great, thanks. So the systemic bias and ableism, I'm going to talk more about ableism. The bias is kind of rooted within ableism, but having meaningful and purposeful lives, a community voice with a history of self-advocacy where we live, learn, work, and play. So this, the ableism, when you look at the literature, it fortunately, for very unfortunate reason, really came to the public discourse with COVID-19. And I think this picture of Matthew Foster, it came out early on, very early on, within weeks, of who should not be ventilator worthy. And so the ARC and a lot of the disability rights groups were very active early on with understanding disability discrimination and medical rationing. And I would also say within the general disability community and within, say, self-advocate becoming empowered, there's been a real hesitancy for decades to address the health discrimination, and largely because no one really wanted to bite the hand that feeds them. So when you look at even SABE website, and they do a lot of policy stuff, the first health stuff that they posted was on COVID. And so I think if anything, it really, COVID has highlighted or propelled the disability community to say, that health issues are an issue, and ableism is a huge issue with healthcare. So 101, what it looks like, what we can do to fix it. The world wasn't built with people with disabilities in mind, and because of that, the world we live in is inherently race ableist. I think that's the similar concept of when I started my doctoral program. I had one of my colleagues basically make actually it was the same comment of, you live in a world that wasn't built for, that's a white world, so it's inherently racist, and we all experience racism and ableism. So even if you have a disability, you still have ableist attitude because we live in a world where that's built. So it's a constant effort to really think about what we're saying and doing. But what it is discrimination of and social prejudice against people with disability based on belief that people that typical abilities are superior. So you see in the image the R word, cripple, oh, you're so brave, do you need help? Ableism is rooted in the assumption that disabled people require fixing and defines people by their disability, like racism and sexism. Ableism classifies entire groups of people as less than and includes harmful stereotype, misconception, and generalizations of people with disabilities. 3 different levels, just to tuck away. On an institutional level, the disability is a problem that needs fixing, pervasive in teaching. That's why in education, nursing education, students come in with pretty positive ideas and thoughts about disabled people. And the literature has been really clear, not much, but since the Biller study in 1990, that the higher the education, the worse our attitudes are toward people with disability. So there's something systemic going on that's resulting in that interpersonal ableism take place in social interaction and relationship. A parent of a child with a disability might try to cure the disability rather than accept it. When is enough enough? That's a really hard concept to know. And then internal, a person consciously or unconsciously believes in the harmful messages that they hear about disability and applies it to themselves. And then a person may feel that disability accommodation a privilege, not a right. And so unlike the feminist movement that had a lot of grassroots movement, when the ADA was passed, we never had that movement. So we really never understood what disability discrimination was. So form in healthcare hostile. This includes, as I mentioned in the Akron group, home aggressive behavior, such as in policy that allow bullying, abuse, and violence. Benevolent, this form views people with disabilities as weak, vulnerable, and near rescuing. This is patronizing and undermining the person's individuality and autonomy, reinforcing an unequal power dynamic. And then ambivalent ableism. This is a combination of both hostile and benevolent ableism. A person might start a social interaction by treating someone in a patronizing, patronizing way, and then switch to being hostile if the person objects to the behavior. And this is really, all of these are really common across all people with various types of disability. So ableism affects people differently based on how others perceive, geez, I can't stop this. Based on how others perceive their disability. How people discriminate against those with visible impairment, different from those with non-apparent. I really don't like invisible because it conjures up in it other images. So I like non-apparent impairment because they're just non-impairment, non-apparent. People are trying to hide them. Is impairment physical or cognitive? Is it a condition well known to the public? Really common in nursing education to do the checkbox of having the mom or sometimes the dad of someone with Down syndrome come and talk, and that's their whole course on disability. Does a particular disability have a history of being stigmatized, as this can lead to the development of specific myths and stereotypes or slurs? And I would say that facial disfigurement, so like burns or various other craniofacial conditions, are a big one for societal discrimination. So the images, you don't look like you're disabled, and can you have sex, are just kind of common one. People with IDD are regularly dehumanized and devalued. We kind of think that people don't have human feelings or emotions, and I think that they're less than human. They're unable to feel basic physical sensations, such as pain, cold, hunger. I don't know how many times I've heard as a nurse, they have a developmental disability. They don't have the same level of pain. Could be that no one has ever valued their pain, so they've learned to give up, do not make worthwhile contributions to society, therefore viewed as less capable, and then they're incapable of making decisions for themselves. Therefore, they should not be allowed to control their finances, own a home, develop emotional relationship, experience normal sexual feeling, or control reproductive decisions. Back to the health equity requires anti-ableism. And I like this slide because I think it might get at the root as to why the more we educate healthcare students, that their attitude to become more negative. And so at UIC, we have a culture and art center. And I think that we've done a lot in the general society of getting some of this information out, but we really haven't touched bringing that work into the health education. And I think Suzanne Smeltzer's work of really looking at what we have in our book, and do we have images like on the top right of the picture where we see people with disabilities out in the world, or do we have more pictures from journal where we see images of children and adults as teaching tools? And so when images of normative bodies are the ones that are most often seen, both in the media, mainstream, and in our health education, what what do we end up with, and where do we go with that? So how can we combat learn about ableism? So disability is just another way for mind and your body to be. It really just is a different, and the beauty in it, it adds to our community, adds to our society. Disabled people are not here to educate you at your whim. I know that came up in our disability simulation project at UIC. If you've been socialized that your role in society is to educate, why would you not always say, yeah, I'll do it? If you've never really had the opportunity to deconstruct what it means, disabilities vary. Some are some are not apparent. Stop looking for faker last week. And that comes out with Social Security too. and I understand there's a lot of issues, but it's just something to tuck away. Last week, disabled people are not here for ableist comment. And then the extra, no disabled person can speak for all. How else can we combat? Hire people. We don't. Even in my own department, we had an equity position, and we didn't include disability. That's a whole other topic. But we have a long ways to go. Follow disability activists on social media, push for greater accessibility, and then avoid ableist labels and expression. We found this Savior design system to Ally design system. And it's a relatively new sort of approach for equity empowered system. And today's health disparities are not an accidental history of segregated care with potential resurgence in complex care clinic. You've been in the profession long enough, or in the area long enough, when you see history repeat. So Savior design system devalue individuals' lived experience. Healthcare decisions are made without incorporating individuals' opinion or how ableism and oppression have impacted their health and behavior. Ally design system builds self-awareness among oppressing group while partnering with oppressed group to spark change. Recognizes that individual unique circumstances and social conditions affect their health and need to be factored into healthcare decisions to provide quality care, reflect on lived experience, points of privilege and oppression to inform additional perspective needed at the table, quote unquote. Intend to identify and challenge institutional and systematic oppression. Equity empowered system amplify lived experiences and actively address root causes and barriers of navigating the system, and to improve population level health. So considering allyship, I like the continuum, apathetic, no understanding, aware, no basic concept, active, well-informed, sharing, seeking, and advocate. And I think hopefully with some of the concepts presented today, you can kind of tuck them away and use them wherever you see applicable. Where can we provide opportunities for people with disability to share their joys and pain? Where can we reflect on their pain? There's a great quote, the book Jerry Banks, I forget the author's name, but he talking about his experience as an African-American kid in a private school, and he was keeping a journal, just to himself, mostly white kid, all white kid, and he lost his journal. His teacher found it, and the teacher said, "Why are you so angry?" And he said, "I'm not angry. I'm just writing down what I experienced." and he made the comment that he expected that or appreciated that the teacher was less interested in his pain than her feeling better about herself at the end of the day. And I think in many sense, that's the point of allyship, is we do have to appreciate the pains that people experience and recognize that we all play a role in some of those pains. How can we lift up others, lift up ourselves as health advocates? What's the impact of empowering people in the disability community and objectifying people with disabilities? We've talked a little bit about universal design, moving beyond ramps to cultural humility, advocating for access, self-advocacy movement, ensures accessible, inclusive healthcare. A little dense cultural humility, but of note, and disability 2020 study. This is kind of appalling. Close to 84% of healthcare professionals implicitly prefer people without disability. These professionals may view people with disabilities as having lower quality of life or being unwell as a result of their disability. I'm not so negative on that. I actually, in doing the work that we've done for 20 years with direct support professionals, I've always said, direct support professionals don't wake up in the morning and say, today is going to be the worst. I'm going to treat people as poorly as I can and do as bad of a job as I can. I think it comes back to that systemic piece of it, that direct support professionals are low paid. And I think when it comes to healthcare professionals, when you see a person with a disability, you know that there's more time involved. So I don't know that it's so much that people are not like, certainly we saw with COVID, with the, restricting ventilators, that certainly was a bias. But I think there's 3 points that we need to just ponder. We need to shake our collective self free of that convenient illusion that we are off the hook because we know ourselves to be kind, compassionate, and professional in all our patient interactions, regardless of race or disability or privilege. That's just not enough. Rather, we need to understand that simply by living our daily life within a system that affords us unearned privilege, that we are complicit in benefiting from it. And then and this is why we really need to have more healthcare professionals with disabilities. We who are free from the daily fear of encountering hateful attitude or more subtle microaggression from the person, institution, and system of those around us have a special obligation to be allies of those who are not. Oh, I should say, the author, Laura Van Pumbrook, she's done some really nice work around explicit, implicit attitude. I would also look up her work. She actually went through UIC disability studies and OT program. She's at Rush in OT, but love her work. Notes from patient. This is from our study a couple of years back. I wish my healthcare provider would, in terms of healthcare, provide resources on medical supply companies, strategies to find disability-friendly providers, negotiating referral to other providers, educational, employment, financial, health insurance, peer mentoring, opportunity, vocational rehab, accessing health insurance, negotiating employment, SSI benefit. And then the cultural piece, peer support, learning about identity, culture, disability pride, home modification, and in-home support and assistive technology. So really things that would allow people to function in life. This is the just universal design, not going to go into it, but this is a standard sort of definition. Design for all, inclusive design, barrier-free design. Internationally, I think some other countries have done a little better job than the US. These are some of the common symbols. And then these 7 factors of tolerance for error, perceptible information, low physical strength, equitable use, simple, intuitive, size, and flexibility in use. These should all be incorporated when we think about healthcare spaces and community spaces. And then the physical and environmental access. What physical and environmental mod do you need to include? Principles of universal design. And so these are just basic things to go to a doctor's office or an ER, a nurse practitioner, minute clinic, wherever you go. Can people, how usable are your healthcare services and facilities? Can people access the front desk and are staff trained? Can your patient move freely throughout your facility? And then including getting through doors and into the bathroom. Can people be weighed who cannot stand on the scale? I recently heard somewhere in Texas that the only scale they had was like at a local zoo for someone who had significant obesity. Obtaining, filling out paperwork support. And so I think it's not really complicated, but these principles really work for everyone, and it's still not uncommon to have like a lower front desk, but all the equipment is at the high level. So if you do come to the lower front desk because you're using a wheelchair, you're not going to be able to communicate because they don't have any of the equipment there. And also exam tables are still not usable, and many providers still won't lift you to the exam table. So that's an issue. Person first versus identity first language. So there's been a more recent shift from person first. I am a person with a disability. I am a disabled person. And tends to fight back against stigma and emphasizes personhood. And then the identity first intends to recognize disability and disabled as indicators of identity and show disability is not a source of shame. And then I think what we're seeing more recently is language is not a one size fits all. Individuals in different communities have their own preferences, and whenever possible, just ask how a person chooses to identify rather than assuming. Okay. And then opening communication. I still really like, in order to afford access, how can we best arrange your appointment to meet your need? What are your communication needs? Who will come with you? And how can we best work with you to meet your need? And I like this image. Communication and involvement should be recognized and valued as essential and integral to how we support people. So I'm not going to go over all of these, but my communication partners listen to me. The different services that I access, share information if I want them. So information that affects me is made accessible to me. We have concerns with the move to electronic health records. It's really pretty complicated for people who have computer literacy, let alone those who don't. So good to be vigilant with how we're translating information. And then creating respectful interaction. I love the image. Waiting room, the doctor will see you now. Here's your medical jargon dictionary. I think in the healthcare industry, we're really good at a lot of metaphors, and metaphors are challenging for people who are English second language, challenging for people who are deaf and hard of hearing, challenging for people who have cognitive impairment. So really best to just stick with plain language. Treat people, ask if people need assistance, treat people as people, and don't assume that a person with a disability is more fragile. Introduce yourself. And anyone who else who might be with you, ask how best to converse. Wheelchair user, a person who is short stature, someone with autism, person with hearing, vision, or speech disability. Navigating communication style, speak clearly, repeat, rephrase, write, type, face me. Those are just some basic ones. Minimize background sound for universal communication. If you don't understand, say so. Ask if there's a better way to communicate. Ensure well-lit area. Keep hands and objects away from your mouth. I can say in my decades of life, I've only had one person, one physician ever consciously speak to me without, barriers in the way in a healthcare interaction. Communicate, and that physician actually was trained up in Boston at a deaf and hard of hearing clinic. So he got the memo and he kept it. Communication access, if someone uses communication device, ensure access to device. Ask how much time is needed. Ask questions requiring short answers, nonverbal communication. So yes, no, blink, blink what the basic. Communication board, the excellent ones that come in a packet that you can get online. So you can always use those. Virtual communication, ensure availability of speech to relay device, open captioning, etc. Health literacy and healthcare and health outcome. Current focus is on improving person access to health information, capacity to use it effectively with UD and UDI. Patients with low health literacy. CDC has done lots of work, so I encourage you to check out their information on emergency room, hospital treatment plan and mortality rate. High health literacy results in improved overall health status, decreased hospitalization, correct medication use, less severity of illness, and greater knowledge of health status, better disease and treatment knowledge, more positive and healthcare perception. We barely have scratched the surface of thinking about health literacy for people with IDD. And then accessible materials and content, just some basic thoughts of accessible brochure materials that present information with simple background, high contrast, consistent page layout with clear uniform font size, style, aerial time enrollment, multiple modal communication, so visual, auditory, tactile, incorporate multi-sensory messages. These are just some universal design resources for you. I won't go. Center for Inclusive Design, the R.L. Mace Universal Design Institute, the 7 principles I mentioned, Washington, University of Washington, they've long been working on universal design, so they're a good one to check out as well. And then the first one is a universal design healthcare manual, and that came out right before COVID, and it was a beta. This was in Kyiv in Ukraine, but they've done quite a bit of work around universal design as well. Discussion questions. Jasmina, do you want to?
Yeah, Beth, I'll take over with discussion questions and give you a second to catch a breath. So we have some discussion questions. We have a little bit over 10 minutes to talk about some of these. we've given you a snippet. It's a pretty dense snippet, and it really talks to, you know, the need for health advocacy and multi-level approaches of health advocacy that include systemic, individual, and self-advocacy. So if you have any questions, feel free to ask them of the presentation, but also we wanted to ask these discussion questions, and you can pick any that you feel like answering. And the first one is, what is the role what is the nurse's role in patient advocacy? What type of advocate are you? And I know we've had some of these discussions during the evening sessions and even during the May 4th discussion. And what skills do you need to have in order to engage in advocacy on social determinants of health? Are these skills similar or different based on your advocacy goals or focus areas? How can your organization create an environment in which you can safely take part in advocacy efforts? What actions can your organization take to ensure that its own policies and practices are consistent with its advocacy goals? And then the last question, in what ways can you and your organization contribute to advocacy efforts that address policy and social change at the structural level? So feel free to just unmute yourself and comment on any of these questions, or even just ask questions of us. Beth, can you put, yeah, thanks. Okay, Suzanne, you're clapping. Anyone raise question?
That's not what I meant to do.
Oh.
What I meant to do was to raise my hand. One of the earlier slides, and I'm not asking you to go back to show it again, but it talks about advocacy as a continuum. I think it was called the Ally Continuum. And I think it's an important point, because one doesn't get born as an advocate. You know, it's a developmental process. And I think initially, you know, it may be sort of fact-finding. And there, on that slide that you showed, there are about 3 or 4 steps where you finally got to the point where you would probably be adequately adequately described as a true advocate. And I think that's something important for us to keep in mind, that we're not born as advocates, and it's a developmental process. That's my only comment.
Thank you. And that was Beth's slide 25. So it does go, the allyship continuum is, it's almost like stages of change. You don't have an understanding of the issue, and then you go and seek the knowledge and understand the basic concept, but you're not necessarily active on behalf of yourself or others. And then that awareness becomes, you may just stay at that stage, but hopefully many people move to that action stage where you become more informed and are able to share and seek diversity and become an advocate.
Yeah, I would actually think that the first step should be ignorance rather than apathetic. Meaning that you have no knowledge or understanding of the issues, you're ignorant of them, or perhaps lacking knowledge, and then moving along to awareness, active, and then advocate.
Yeah, great point. Thank you. Cynthia, you had your hand raised?
Yeah, I was just thinking that sometimes you don't even think you're about the advocacy role, but sometimes it just happens. When I got my mammogram and my DEXA scan, which is oftentimes what our patients get, I talked to the tech, and I was talking to her about it, like how hard it would be for somebody in a wheelchair to have to come into this environment to get a DEXA scan and a mammogram, and she really never thought about it. It just came upon me while I was there, because it was kind of hard for me to maneuver, just to mention that to her, and to see, me and her had a conversation about what she could do to make it easier, because oftentimes the environment limits what kind of healthcare we can do for our patients. So
This is Suzanne again. I absolutely agree with that. I think every time I have a mammogram done, I ask them, how would you do this if I had a disability and I couldn't stand? And very often they have no idea, they never thought about it, or they say, oh, we can accommodate people. And that's the end of their discussion. I wonder if they really can.
and I think how it made me think about it was some staff, I was covering a house or something, and staff asked me, could they pick the person up and lower them down on their their table? Because that was going to be the only way that they were going to be able to do it. And I had them bring their wedges from home. I had them bring them with them. So, you know, I ended up going to the same place. So that's how I understood that.
Any other questions or comments? I'm specifically interested in any examples or stories of your role in patient advocacy that you may have had.
I actually have something to kind of discuss on 3. So it says, what skills do you need to have in order to engage in advocacy on social determinants of health? I've been thinking about this in relation with disability because the term used a lot is disability poverty or enforced poverty that is kind of the current structure of disability in the United States, where there's, you know, maximums of amount of money that people can have and a lot of kind of restrictions. And so one of the things that I think, what skills do you need to have in order to engage in advocacy on social determinants of health, especially around people with disabilities, is an understanding of how it can look different than what you think when a person is experiencing poverty, when a person is experiencing structural racism or something. And so one of the skills you really need is kind of centering the voice and experience of those who are experiencing it rather than what you think it should look like. And, you know, just how it's easy to make assumptions, and something I have to constantly check myself with, like, how is this person doing X, Y, and Z when they're in this situation? And it's like, that's my assumptions of what it means to be a person in this situation, not their experience of it. And I need to, like, take a step back if I'm an advocate, not judging them or not saying this is right or wrong, but saying, what's going on in your life that this is the shape of it, and how can I advocate you from your own position, not from what I judge you as being needed or not needed.
Therese said, absolutely, Guy, very important skill to listen closely to those who are in the situation and what they may want to see in terms of solution. Thank you. Anyone else? Any other comments on any of the questions? Oh, Melissa, do you want to expand on a comment to moral imagination?
Sure, I'm just following up on what Guy was saying. I hear that completely, and I appreciate that comment. Within global health and global nursing, one of their ethical frameworks for interaction is moral imagination, where you need to have the skill to be able to imagine yourself from that person's experience, almost like empathy, but it takes your imagination, because you have to, like according to Carper, right, unknow our assumptions and unknow all of the things that we're assuming, and then imagine from the other person's worldview. And so that's really the term that they use in global health, but I think it's relevant here as well, because sometimes I think we we make a lot of quick judgments that affect the care of people with IDD, and we don't take the time to imagine life from their side. And of course, that's, as Guy says, right, we need to ask, and be part of that conversation.
Can I follow up and ask Melissa a question? In addition to moral imagination in terms of sort of thinking about what it must be like, am I correct that the next step is to verify with that person?
I think in order to have a moral imagination, it's informed by cultural encounters, by encounters with people with disabilities. But I don't think it's necessary that you're imagining it on your own and then verifying. I think your cultural imagination has to come into play, or your moral imagination has to, I don't think it's supposed to be something you do independently.
Okay. Because one could imagine something but be inadequate or incorrect. So that's the reason I was asking the question.
Yeah. Melissa, I'm really interested. Can you just talk some more about how moral imagination is related to, but different than empathy? Because when you were speaking, I was just constantly thinking of that notion of empathy, trying to see yourself in the other. And so moral imagination is a very intriguing concept. I'd just love to hear a little bit more about it.
Sure. So I think that empathy is more affective, right? We talk about empathy in the affective domain. In my understanding, moral, and that I keep saying cultural, but it's very closely linked with cultural humility, which is why I think that word keeps coming out of my mouth, cultural. But moral imagination, really looking at the idea of, as we're looking at it and as we're looking at ethical problems as well, like, so for instance, in terms of social determinants of health and people with disabilities, and how do we allocate resources, limited resources, which we know in the disability system are often very limited. But as we look at almost like questions that are right or wrong, that's the moral part, right? Like recognizing and understanding at the same time that the way we see things doesn't necessarily make something right or wrong, because there's that element of things being relative, right? Because it's not all from our own mindset and from our own framework. So I think there's more of a piece of, as we're making decisions, that's the moral piece, as compared to empathizing, which is really the feeling piece. Mm-hmm. There's a really great book edited by William Rosa, and it's in the realm of global health, but it as I'm reading really almost anything to do with global health, and not international, but global, the piece meaning like we're all interconnected, and what happens with one group affects everybody else. Almost all of it is completely relevant to people with IDD, because of course we're all part of the same global community. So there's a lot of cross links there.
Thank you, Melissa. I quickly, I put a quick read in moral imagination to everyone in the chat. And then William Rosa, is that a new era in global health book?
It is. Yeah, it's fabulous.
I'll put that in the chat so everyone can have it as well. All right. We are at the hour. Thank you so much for this discussion. I know that there were some additional questions for Layla, so we're going to keep this communication open. We do have about 30 minutes of I guess 20 minutes now. Is that correct, Darcy? Of break, and then we will come back to our next presentation. Do we take it to 11 p.m. 11 a.m. So 20 minutes.
Our next, just to honor the time of our presenters from the ARC who are joining us. I think so.
All right. Thank you so much.